Welcome to episode 30 of the Pro PA podcast. I'm your host, Prof. G, and today we're tackling chronic obstructive pulmonary disease, or COPD, including its two main subtypes, emphysema and chronic bronchitis. COPD is one of the most common and preventable chronic diseases worldwide. In this episode, we'll break down the essentials of COPD, including pathophysiology, clinical presentation, diagnosis, and management strategies so you're prepared for both your PANCE and clinical rotations. Let's dive in. First, let's look at the kinder patho. What is COPD? Chronic obstructive pulmonary disease, or COPD, is a chronic, progressive lung disease characterized by airflow limitation that is not fully reversible. It is caused by a combination of chronic inflammation, destruction of lung tissue, and airway narrowing due to long-term exposure to noxious particles or gases. Now, there are two main subtypes of COPD. First, we have emphysema, and this is defined by the destruction of alveolar walls and loss of lung elasticity. This results in air trapping, hyperinflation, and reduced gas exchange. So I think of it as lung parenchymal disease or tissue disease. And the counterpart to that is chronic bronchitis. Now, this is defined by chronic productive cough for at least 3 months in 2 consecutive years. And this is caused by inflammation, excess mucus production, and airway narrowing. Now, in the textbook world, they tend to really separate emphysema from chronic bronchitis, but in the real world, we often see these two overlapping each other in a mixed picture with our patients. So going a little bit deeper into the kinder patho, we generally see an inflammatory response, and this is chronic exposure to irritants, namely cigarette smoking. And this triggers inflammation in the airways and alveoli. Over time, we start to see this airway remodeling, especially in chronic bronchitis. You get this inflammation, which leads to thickening of the bronchial walls and increased mucus production. You also get alveolar destruction seen in emphysema, and the alveoli lose their structure and their elasticity, and they reduce the surface area for gas exchange. We also see airflow obstruction, which causes increased resistance to airflow and leads to difficulty exhaling, causing air trapping and hyperinflation. Now, what are the risk factors for COPD? Well, number one is going to be smoking. Cigarette smoking is the most common cause of COPD and is responsible for 90% of the cases. This includes secondhand smoke exposure. So this is highly preventable. Number two, we see environmental exposure, so long-term exposure to things like air pollution, chemical fumes, or occupational dust like coal miners can predispose you to developing COPD. We also see a certain genetic predisposition. Alpha 1 antitrypsin deficiency is a genetic disorder leading to early onset of emphysema. So generally we will see this in younger patients without a smoking history. We also see it typically diagnosed after the age of 40 and more commonly in males, though it is rising in females overall. Clinical presentation. So the general symptoms of COPD are going to be progressive dyspnea, which is worse with exertion. We're going to see a chronic cough, which can be productive or non-productive. We have increased sputum production and frequent respiratory infections. Now, to further break it down based on the subcategories, emphysema, we like to term the pink puffers. And they tend to be very thin, cachectic appearing. They have a barreled chest due to the hyperinflation, and they often use this pursed lip breathing. And this is to increase the expiratory pressure and prevent airway collapse. They have dyspnea as their predominant symptom. Now, in contrast, we have chronic bronchitis, which we tend to call the blue bloaters. And these tend to be overweight or cyanotic appearing, hence the blue. They are chronic and they have a chronic productive cough with copious mucus production. They also can have some peripheral edema from cor pulmonale, and they tend to have frequent exacerbations. Now, diagnosis. Pulmonary function testing, we can use to help make the diagnosis in the setting of someone that we suspect for having COPD. We're going to use spirometry and do the spirometry type testing. We will look at the post bronchodilator FEV1 to FVC ratio less than 70%, and this confirms airflow limitation. And we also see a reduced FEV1, which correlates with severity. We also can look at a chest x-ray. So with emphysema, we tend to see these hyperinflated lungs with a flattened diaphragm and increased AP diameter or barrel chest. For chronic bronchitis, we tend to see an enlarged heart and maybe some increased bronchovascular markings. We can also elect to do an ABG or arterial blood gas. And what this will typically show is chronic respiratory acidosis with some hypoxemia and hypercapnia. It's more common in chronic bronchitis. We can also look for alpha 1 antitrypsin. This is recommended in patients with early onset COPD or a family history of the disease, plus or minus the smoking history. So, as far as classification of COPD severity, we tend to use the GOLD classification, which stands for the Global Initiative for Chronic Obstructive Lung Disease. And this classifies COPD severity based on the post bronchodilator FEV1 on PFTs. So, the first category is going to be GOLD 1, which is considered mild, and this will be the FEV1 greater than or equal to 80% predicted. Then we have Gold 2, which is considered moderate, which is an FEV1 between 50 and 79% predicted. Then we have Gold 3, which is considered severe, and this is an FEV1 between 30 and 49% predicted. And last but not least, we have the Gold Category 4, which is considered very severe, and this is an FEV1 less than 30% predicted. This classification helps guide treatment decisions along with the symptom burden and frequency of exacerbations. So, how do we manage these types of patients? Well, number one, smoking cessation is found to be the most effective intervention to slow disease progression. This is going to be so crucial that we help our patients succeed in quitting smoking. Second, we have some pharmacologic management. Remember, COPD is never fully reversible, but we do have some, or we can see some improvement with certain pharmacologic managements. So we want to use short-acting bronchodilators like SABAs or SAMAs for symptom relief like albuterol or ipratropium. We also can use long-acting bronchodilators like LABAs or LAMAs, and these are for moderate to severe COPD like salmeterol or tiotropium. We also use inhaled corticosteroids that we add it on for patients with frequent exacerbations. There are also some PDE4 inhibitors for severe COPD with chronic bronchitis. And we sometimes have to resort to using systemic corticosteroids, especially in those acute exacerbations, as well as oral antibiotics. As far as oxygen therapy, we want to use this for patients with chronic hypoxemia with an SpO2 less than or equal to 88%, and this is shown to improve survivability in severe COPD. As far as pulmonary rehab, there are some exercise trainings and education that we can use with our patients to improve quality of life and the functional capacity. So we can refer them for this, as well as some surgical options. So sometimes we can do some lung volume reduction surgery or even a lung transplant in select patients with severe emphysema. Now, we just talked about the management overview, but we also have to look at the acute exacerbations of COPD, which is a hallmark finding. One, we need to look at the triggers. So, respiratory infections like viral or bacterial infections can trigger acute exacerbations of COPD. And also things like environmental pollutants or non adherence to therapy or to treatment can induce these exacerbations. For management, we really want to stick to the bronchodilators like nebulized albuterol plus or minus ipratropium. We also can use those in systemic corticosteroids like prednisone for burst treatment, as well as antibiotics. So, for exacerbations with increased sputum purulence or volume, we want to include these antibiotics, something like azithromycin or cephalosporin, to target bacterial types of exacerbations. We also want to consider oxygen therapy to maintain that SpO2 between 88 and 92% at least. So book med versus treatment. So textbooks are going to recommend that stepwise escalation of bronchodilator therapy and regular PFT monitoring. It's also going to emphasize long-term oxygen therapy for patients with chronic hypoxemia. Remember, book med is also going to separate emphysema and chronic bronchitis into two completely separate boxes. Street med, however, in the real world practice, many patients delay seeking care until they experience severe exacerbations. Smoking cessation remains a significant challenge requiring ongoing education and support for our patients. And there's a lot of non adherence to maintenance therapy, especially with inhalers. So it's really common, and we must address these during our routine follow ups with these patients. Last but not least, remember that emphysema and chronic bronchitis tend to overlap in our patients, so don't always expect to see the two distinct subcategories. All right, some quick clinical pearls. Smoking cessation is the single most important intervention in COPD management. 2. COPD exacerbations are often triggered by infections, so look for increased sputum volume and purulence. 3. Always suspect alpha 1 antitrypsin deficiency in young, non smoking patients with COPD. Number 4, chronic hypoxemia in COPD is managed with long term oxygen therapy, but avoid over oxygenation to prevent CO2 retention. And number 5, vaccinations. So we need to be prudent in figuring out which types of vaccinations our patients need, including influenza and pneumococcal, to reduce exacerbation risk and improve outcomes. All right, so now let's test our knowledge. We have a 65-year-old male with a 40-pack year smoking history who presents with a chronic cough and dyspnea. Spirometry reveals an FEV1 to FVC ratio less than 70%, and a post-bronchodilator FEV1 is 55% predicted. What is the most appropriate next step in management? Is it A, smoking cessation and albuterol is needed? B, initiate oxygen therapy? C, start tiotropium, a LAMA? Or D, refer for lung transplantation evaluation? I'll give you a few seconds. So if you said C, start tiotropium, you are correct. So this patient has moderate COPD with an FEV1 of 50 to 80% predicted. So in this case, a LAMA is recommended for symptom control and to reduce exacerbations. Now, this is not to say that we are not going to encourage smoking cessation and give the patient albuterol as needed, but we do need to step them up to a long-acting agonist. But we do need to step them up to a LAMA in this case. All right, question 2. A 70-year-old female with COPD presents with worsening dyspnea and purulent sputum. She is hypoxic on room air with an SpO2 of 86%. What is the next best step in management? Is it A, nebulized albuterol / ipratropium and systemic corticosteroids? Is it B, oxygen therapy to maintain an SpO2 greater than 95%? Is it C, initiate antibiotics and discharge home? Or D, order a chest CT to rule out malignancy? I'll give you a few seconds. If you said A, nebulized albuterol and ipratropium plus systemic corticosteroids, you are correct. So this patient is experiencing an acute COPD exacerbation and requires bronchodilators, corticosteroids, and supplemental oxygen. We can also consider initiating antibiotics, but we do need to keep a little closer eye on these patients, so I probably wouldn't discharge them home, at least initially. All right, well, I want to thank you for joining me on this episode of the Pro PA podcast. I hope this has clarified some of the key concepts of COPD and its subtypes, emphysema, and chronic bronchitis. And I hope you stay tuned for the final episode in our obstructive pulmonary disease series, where we'll cover cystic fibrosis. If you found this episode helpful, hit follow and turn on notifications so you never miss an update. And as always, this is the Pro PA podcast, where future pros in medicine are made. I'll catch you soon.